I don't have an issue with incentives, but they should be aligned with the right outcomes. And the right outcome isn't, oh, you almost died and I brought you back to life. That shouldn't be the outcome we're looking for, because that's how we're really good at that. We're really good at acute care. We're really good at bringing somebody back to life when they've been, they coded for a certain amount of time. But we're not good at preventing people from getting to that point. We're not good at preventing little kids getting type 1 diabetes en masse where it's an epidemic. We're just not good.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. In this episode, we're joined by special guest Lucy Janoyan, Chief Strategy Officer at Biography Health. With over 2 decades of healthcare executive experience, Lucy explores the transition from reactive to proactive healthcare. She discusses the challenges facing primary care providers, the role of genetic testing in personalized medicine, and how Biography Health is working to empower both patients and ultimately providers. Lucy shares insights on continuous health monitoring, patient engagement, and the future of healthcare, offering valuable perspectives for healthcare professionals and health-conscious individuals alike. Hey everyone, welcome to today's episode of the Precision Medicine Made Simple podcast. We are thrilled to have a remarkable guest with us, Lucy Janoyan, the Chief Strategy Officer at Biography Health. With over 20 years of experience as a healthcare executive, Lucy has been at the forefront of transforming healthcare delivery, from launching innovative multi-state telehealth platforms to co-leading private equity-backed company exits. Lucy's impact spans the entire healthcare spectrum from pediatrics to hospice care. In this episode, we're going to be diving into some of the biggest challenges facing our healthcare system today, particularly for primary care providers, and exploring how personalized preventive care can be a powerful solution to these challenges. We are with Lucy. Dr. Stanford, welcome to the show. Thank you so much for coming by.
Thank you for that introduction. Glad to be here.
Yeah, and from my understanding too, you actually worked with Dr. Stanford quite a bit. Well, not quite a bit. From some time ago. How did you two meet and get connected, and then also reconnected to join Biography Health?
Yeah, so we met actually when I started my first operations leadership role at a company called Country Villa Health Services, and this was over 2 decades ago. I worked quite a bit with Cedars-Sinai Hospital. We would get a lot of their patients, and I met Dr. Stanford right when he was pioneering hospital medicine. So I didn't know it at the time. Many of my colleagues didn't know it at the time, but hospitalists essentially were physicians rounding in the hospitals and seeing all the patients before they were discharged to go home or to go to a post-acute care skilled nursing facility. And Dr. Stanford was not only the first hospitalist, but he grew his hospitalist practice and had a larger medical group over the years. So we stayed in touch. I worked with him in multiple capacities, of course, as a physician for some of the patients that he sent over to our facilities, but also as a leader and a pioneer in his domain. And also he became a medical director for some of our healthcare facilities to advise on quality of care, on metrics, utilization. So we got to know each other. I was always fascinated that he was an engineer, essentially an aerospace engineer, and decided, you know what, that wasn't hard enough. I'm going to go to med school. I'm going to get a PhD on top of that. So incredible kind of admiration, really, for such a learning mindset, a growth mindset. So I just always loved to talk to him, because every time I talked to Dr. Stanford, I learned something new to this day. And we became friends. We stayed friends. We would touch base and kind of find out how his career is going, how my career is going. And I knew that he had entered a world of precision medicine. Again, something brand new. I started exploring, and I thought, wow, this is fascinating. Would love some uptake on this in the healthcare industry. And then we connected in person with his beautiful wife as well over dinner. And I decided, wow, this is an incredible journey that he's on with such a great team. Let me join that team, upon an invitation. And here I am. So that's our story.
Yeah, awesome. And so what is fascinating to me is you had this interest within precision medicine and what Dr. Stanford was doing. And given both of your experiences in the healthcare space, it almost sounded like there was that fascination that stemmed from a challenge, an obstacle, a problem with the current state of healthcare. And so I'd love to hear both of your takes and what the both of you have experienced within the current state of healthcare, and why you're now moving towards this precision medicine and personalized approach.
Let me start off by mentioning my recollections also when we first met.
You can do that.
So, and this will go a long way toward explaining or getting at the answer to your question about this intellectual curiosity and this desire to move the field of medicine forward. So what Lucy didn't tell you is that she had immense responsibility from very early in her career. And so I wasn't the only one that saw the talent in her. The people above her saw talent in her, and she moved quickly up the scales and really put me on to a lot of things that were very helpful in that transition of care from the hospital outside of hospital. When she left that environment, and she'll probably be talking more about this, but she got into pharmacogenomics a little bit, which was also a bridge for us. So anyway, go ahead and pick it up from there. The pharmacogenomics was some years ago, right when I was starting to see the value in precision medicine, and that really accelerated us ultimately to the point we are now.
Oh, absolutely. Actually, I was in behavioral health. I entered a world of behavioral health services in 2016. Fast forward about 3 years into my tenure at the organization, I met with a company called GeneSight, and I was just amazed at the technology, because essentially they had not only they had the reports where they could swap patients and send back reports showing which psychotropic medications were safe, unsafe, or to proceed with caution for the geriatric population, especially those in residential or skilled nursing facilities. But they had enough evidence to have Medicare pay for it. So to me, this was such an amazing step forward from the science perspective, from the medicine perspective. And of course, I knew, well, the only other person I know that would really appreciate this is Dr. Stanford, because I knew that he had the Beverly Hills Precision Medicine Institute. So I called him. I said, look, I have some interesting people I'd like for you to meet, because I think that your patients may benefit, and also wanted to see how we can work with this organization to evangelize something so great that Medicare is also paying for. So that's when we met. We met with the scientists, I believe, in the area at the time. So there was that reconnection, but there have been multiple points of reconnection with Dr. Stanford and I, and they've been around health. I remember a conversation we talked quite a bit actually about telomeres and the length of telomeres and how that determines your longevity and lifespan. And just a quick background on me from an education standpoint, I actually studied gerontology in college. So the topic of longevity, the topic of human development, and the psychobiosocial model has always fascinated me. I've always wondered what happens to us as we age. And of course, this was not a very sexy topic back in the day, right? I had friends who thought I was studying rocks. So gerontology, not geology. But when I would tell them, no, it's gerontology, it's the study of aging, the second response, old people. Why do you want to study old people, right? So most people don't understand that we start aging very, very early on. Some can argue in the field that you're born and aging is just a natural process, right? We're aging from the day we're born. And then there's accelerated and transition points as we move on. But going back to that curiosity that you mentioned, Dr. Stanford, I know you have that. I know I have that. I think people working at Biography, everybody at Biography has that, right? It's that passion for understanding how that impacts health, right? But going back to Taylor's original question, that's great. Now we know how aging impacts health and what that means, but how is our healthcare system set up to help us with those transitions, right? And we've been in healthcare for years and years, decades, and unfortunately, we've seen what happens when people aren't taken care of, or they don't take care of themselves, don't know how to navigate the system, don't have access to the right information, or the right type of provider, or the providers don't have enough time for those patients. So I just want to kind of go into that. And I do think this is relatable. And of course, there are a lot of system issues, but the good news is we have a solution. So I also spent some time.
Oh, we love solutions. Yeah, no, it is interesting as heck that, I would count me among your colleagues that go, why study gerontology? I have to say that my first exposure to it when I was in residency at UCLA, I'm like, oh my gosh, But what gerontology wasn't so much then, but I think what we've learned in gerontology and what I learned taking care of, older sick people in the hospital for all those years is there is an opportunity. There's a whole new approach to gerontology and aging from how you can age better. And you mentioned the earlier you start, the better. And part of what we do in personalized precision medicine is we look at each individual person and assess where they're going to have the most risk to, in the future, to develop a chronic disease. And there's things you can do now such that that doesn't happen. And now, so lucky Lucy is now an expert in a field where there's tremendous interest in just billions and billions of dollars getting poured into anti-aging. And of course, some of those books out there, like that we've mentioned before, Outlive by Dr. Peter Attia, or The Longevity Imperative. The ability to age better and slow down the aging process and to have a longer health span, those days are upon us.
Yeah.
And personalized precision medicine helps lead the way to that.
Absolutely.
And it almost sounds like you're alluding that the current system that we have now is really not set up for us to age better then.
No, the stakeholders, maybe you could even say, including myself, when I was in hospital medicine, taking care of people, in the last months and years of their life, the healthcare system really should be, this isn't my original, but I love it. It should be called a sick care system, because nothing happens in the current healthcare paradigm until you're sick. I was just talking to the chief medical officer at a large medical practice, like a Kaiser type thing.
The health
Yeah,
plan.
health plan. All right, thank you. I guess that's good news for me that I don't even know what they call themselves anymore. But we were talking about continuous glucose monitors. So in an ideal world, you would assess that someone's at risk to develop diabetes. You would have them put a continuous glucose monitor on, see how their body, interacted with glucose, look for those telltale signs of insulin resistance, and head the whole thing off. While at that health plan, they won't even consider paying for a continuous glucose monitor for a patient. Not if you're insulin resistant. Nope, not going to pay for it there. You're pretty diabetic? Nope, not going to pay for it there. Diabetic? No, not going to pay for it there. If you're a brittle diabetic, meaning that you wind up in the hospital because your blood sugars wind up 700 or whatever, then they'll pay for it. So, and it's not like these things are thousands of dollars. They're like, $40 a piece. You can get a month's supply, each one lasts for 2 weeks. They're like $40 a piece. And you don't have to wear them all the time. You just have to wear them long enough to understand how your body is reacting with what you eat. But anyway, that's probably a podcast for another day. But that is to reinforce the current healthcare system isn't at all predictive, preventive, proactive. It's reactive. It's break and fix. And why does it persist like that? Because there's stakeholders like this health plan that are very entrenched in the status quo, and there's a lot of resistance to moving from that.
And if we can just throw some numbers out there, I think it's the impact that people don't realize. Yes, perhaps, to purchase a CGM or to pay for a CGM for a few thousand patients looks like it's a lot of money, but we think about 90% of the $4 trillion healthcare budget is spent on chronic care management. So essentially almost $4 trillion today is spent on chronic healthcare management in the United States. That's appalling. And only 6% of what's left is spent on pediatric care, where you can make the most impact because of early intervention, and about 3%, 3.5%, or maybe less is spent on preventive medicine, which is our vaccines that we get, our annual physicals, maybe a mammogram, some of the preventive procedures that doctors can order once a year, blood work. That's about 3% of our healthcare budget. So certainly we don't have our priorities straight. And I think that there is a lot of history, right? If we even reference some of the books, but if we go back to the turn of the 20th century, it was because we were fighting infection that was of utmost importance with the invention of antibiotics and, making sure that we didn't have the mortality that we did because of infections. And we're really good at keeping people alive longer. I think we've gotten there. But if we ask the question, the ultimate question, what is the objective of the healthcare system? Is it to extend life? I think the answer is that's one of the reasons that we have a healthcare system, but it's not the only reason. Because I think none of us in this room want to have an extended life where the last 10, 15 years of our life, we have a very poor quality of health. We may be bedbound, right? We may not even have the cognitive health, right? We may be cognitively impaired. We may have dementia. We may be in a wheelchair and just outright miserable. And here's the thing. I've seen those patients. I've seen all of those patients who have lived. I had a patient in a locked dementia facility who had been there for 14 years, had no clue where he was. 14 years in a locked dementia facility. And I can tell you, I don't want to be that I don't
And
want to
what
get
we
there.
know now is that dementia can be delayed, possibly
Yeah.
even prevented altogether. And, back to your numbers, they, and you might know this number better than I, but isn't it like 25 or 30% of all healthcare dollars are spent in the last year of somebody's life?
It's more than that. It's
Yeah. I
more
mean,
than that.
that's just insane,
Yes.
and, if, and I'm sure anyone that would be listening to us today is probably of the mind that we need to be more proactive and preventive. And really what you're saying is what we would like to do is, instead of there be this steady decline from the time you turn 60 or whatever, but, really flatten that curve out so you have the best functional level as long as possible, where theoretically you're you're doing 100% of your activities of daily living and all that right into your 90s or beyond. And just one night you don't wake up. But yeah, it's to extend that health span, extend that length of time where you have a good functional status.
So
You
so if
enjoy your family.
so so as a provider in the room, I'm sure, and I'm sure a lot of providers today, they believe that preventive care is the way to go. They want to provide preventive care. What do you think are barriers for the physicians? What are the top barriers to providing that preventive care? And of course, reimbursement is one thing, but some of the other barriers
Yeah,
that
I mean,
you encounter.
reimbursement is the obvious one. Right now, for what doctors are reimbursed, you have to see a whole lot of patients in a day, and you don't, and that presents quite a few challenges then to the physician. So you don't have that time to go in depth. What I think the strategy that most health plans, thank you for that, and primary care doctors that are like part of health plans and part of the status quo, as it were, is you have to see a lot of patients to make your relative value units, right?
So it's volume versus value
It's volume.
because of the reimbursement, right? And I read this somewhere too, where primary care doctors as a whole actually get reimbursed 25 or 30% less than other specialties. So they have to see more patients to meet those RVUs and even just get enough reimbursement.
Yeah, true story. What other obstacles? The way that we're all trained is to be very keen that anything we do is evidence-based and first do no harm. A lot of so the timetable for anything that change is going to be quite extended, just based on that. When the sequencing of the human genome was only roughly 20 years ago and only widely available, 5 or 10 years ago. And actually only, I'm certain that fewer than one, probably 0.5%. We should look this one. I should know this one. How many people in the world have had whole genome sequencing? I would imagine it's on the order of 1 in 1,000 people. So we don't have those robust data sets. So a lot of what we learn in personalized precision medicine is new information, and we're dependent on the quality of the work that gets done and what gets published in terms of how you use this genetic information and how helpful it can be.
Well, so with using, and I know we've spoken about this in previous podcasts then, in terms of like using this information, I mean, is this subject taught in medical school, and do you see it being a trend moving forward so then we can catch these providers up to speed to be able to use these genetic insights if we are moving towards this trend of personalized care?
Well, certainly when I was in medical school 35 years ago, nothing like this existed. There was, very short shrift, for anything that was preventive and holistic. I mean, actually, just these basic things like diet, exercise, and sleep back in the day, for me, that was considered holistic medicine. That was some other people that went off and did that kind of thing. What I was trained in and what the current doctors, many of them are stuck with, and certainly with this health plan I was mentioning before, is they're trying to bring a minimum level of healthcare, so to hit certain minimums for as many people as they can. And that's a noble pursuit. But the problem with that is that the science of today and what's possible is so much better than that. And the value of what's possible now is so much more value than doing this minimum level of care for as many people. So there's going to be this transition. I don't know how long it's going to take. Things happen slowly and then all at once, kind of like telehealth and Zoom calls, I guess. That was
we'll see a tipping
common thing, and then it was all at once. So so I think in the short term, there's going to be a certain subset of patients that are become knowledgeable about what can be done. As we've referred to a zillion times, there's so much talk out there in the lay press about what can be done in terms of being able to assess your risk and how to mitigate that risk. I mean, that 14-year case of dementia, I mean, how valuable would it have been for that person to know 30 years ago that if they got better sleep and they, avoided, insulin resistance, if they didn't smoke and blah, 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 that they would not go on to develop dementia and have that, unfortunate quality of life for the last years of their life.
I was going to just reiterate what you're saying, because I do think that most people want that kind of care, right? Most people want a proactive approach. They just don't know where to go to get that. And I think we see this now with a lot of direct-to-consumer digital health tech, because people are trying to figure it out on their own, and we don't know how effective that is, how accurate the information is, or what they're able to do with that information. But I did read statistic in a Deloitte consumer survey that 70% of patients want access to a proactive approach to health management, and about 60% actually want personalized medicine. But what you're stating is 100% true, because the majority of the doctors, even though they feel like they want to provide this type of care, they don't have the tools, right? And that's what we bring.
Yeah. So, I mean, that's what personalized precision medicine brings. The people that are going to be the first to really go boldly into this and use this information and integrate it into care plans are going to be doctors who make their living by providing better care than the next doctor. So that's like concierge practices. These doctors that in the past are able to get paid a fee, a yearly fee, a monthly fee, premium, whatever you want to call it, administrative fee, for giving better access to patients and limiting the number of patients in their practice, et cetera. Those people, that's not going to be enough in the future. I kind of joke around with some of my concierge doctor friends. It's not going to be enough to know your patients' kids' names and their golf score and be available all the time. You're going to have to provide better care than the next person if you want these people to keep writing those checks. So that's one set. And then the other is going to be people that are at risk, or if someone gets a heart attack or has a heart attack, or someone develops diabetes. And so these value-based organizations like ACOs with the Medicare or self-insured employers, where they're, quote, personally on the hook if something happens to their employee, and it's a pretty easy sell to folks like that there is an ability now with genetics and bioinformatics and machine learning and AI that we can be very predictive about who's at the most risk. And again, the science of today is awesome. If you're willing to even operate with the usual tools in the established medical establishment toolbox, you can do a lot to mitigate that risk. And if you stretch yourself a little bit and use some of these new modalities, you can even reduce that risk further. I think, again, it's only a matter of time. I think most people would agree. It's only a matter of time before all this information is used in a meaningful way to reduce those risks, prevent the onset of chronic diseases, and extend health span.
And I would say in an ideal situation, we want this care delivered in the medical home, right? Because we have history with our primary care physicians. We have, they have access to our information. We've, in a sense, grown up. Some of us have grown up with our primary care physician. So that's what I think is very unique about Biography Health, because we are enabling the primary care physicians to be able to provide this level of the medicine 3.0 with a Biography Health platform. And I think that's important to note, because there are a lot of direct-to-consumer DNA testing companies out there, and they have some good information. But at the end of the day, if I were to walk in with all those reports and go to my primary care physician, or even go to one of my specialists that I see for whatever reason, they don't look at that data and say, oh, great, I'm so glad you brought that to me. And now I'm so well informed, and I will give you gene-informed care.
That's usually when I'm getting the phone call from one of my doctor friends. They're like,
what is this?
Brought this in. What the heck is this? Yeah,
right.
No, that's a problem. And the other thing, close cousin to that, is I have a lot of patients that want to go through this process, and they want me to continue on guiding them as they get all this done. Now, I always try to loop in the primary care doctors, because that's the best, as you say, their medical home. That's the best way to go about that. But patients themselves say that information delivered directly to them is of minimal value when it's not incorporated into a care plan that's with oversight from their primary care provider. That's how they want it to go. That's been indicated to me.
Right. And if the physician doesn't feel comfortable with those reports, because maybe it's not structured in a way that they typically see their reports, and yes, it has a lot of pretty colors or graphics, that's great. But I know from my experience, if my physician isn't familiar with a certain, whatever ask I have, very dismissive, right? They're very dismissive, don't want to really go into it. They don't believe in it. So the difference is that now Biography Health makes that connection, doctor to doctor connection, and speaks the doctor language, right? And like you said, combines the traditional medicine that's being delivered with this new medicine 3.0, with all the data and the bioinformatics and the insights that's coming out, that's very specific to that patient. And when we show that to the physician, they have an appreciation for it. I can tell you something. Even just recently, I took my mom to a cardiologist, and of course, I'm well educated through Biography Health. I know what to ask for. It's all about prevention, and we're talking about diabetes and how that's a precursor to heart disease, all this stuff, and the doctor, of course, starts to ask questions about symptoms. And I said, well, if we're talking about symptoms, it's too late, because we're not here for symptoms, right? We're here to make sure we don't get to the symptoms. Yeah. And you know what? I got to give it to this doctor. He got it. He got it right away. He paused. I said, we're here for prevention, doctor. And he figured out what I'm asking for, because again, I think just being in healthcare, we pick up a lot of the terminology. And he went further. He's like, you know what? I'm going to make sure she gets the particle size report and all this. So in addition to the CAT scan and all these tests that she's going to do to look at the ultrasound, the CAT scan, and the particle size. And I really truly, yes, the lipids. And I really truly believe that if we have that connection with physicians and specialists, right, Biography Health really enables the doctors to do that because they do want to provide preventive care whenever possible.
Well, yeah, and I think you really captured that dichotomy between the break and fix and personalized precision medicine. So if your first real engagement with a cardiologist is, as you say, if you have symptoms, of course, hopefully you don't have symptoms, but sometimes they'll just have you do a stress test and they'll go, look, you just did a stress test. It's negative. You're fine.
Yeah.
Well,
Yeah.
That's not the question to ask. That's not the question we'll be asking in the future. The question we're asking is this person developing atherosclerosis at an average, which is no good, average or above average way? You're going to want to be aggressive because most people, 35% of people die of heart disease in their late 70s and 80s. The coming world, the late 70s and 80s, you'll still be in your heyday. But the question we're really trying to ask with a cardiology evaluation is, how aggressive do I need to be to make sure that I'm not one of those 35% of the people 40 years from now? And the answer is, if there's atherosclerosis present in any significant degree when you're in your 30s, 40s, and 50s, you're going to want to start treating that medically and with lifestyle and coming with guns blazing from all directions, because your vascular health is everything. It winds up being integral with your brain health as well. So in the new world, we're going to assess that risk much earlier in life, very early in life, and continue to assess it. And if that risk is high, then, as that risk starts to come up, aggressively deal with it and make sure you're not one of those people.
So with patients that are driving this demand for personalized care because they keep asking it, and doctors are the ones that are going to be the foundational cause to be able to drive this forward and really change the whole perspective and system, in considering that there is that time constraint, and then there also is the challenge of getting up to speed with using these genetic insights, then I would love to take just a quick step back then and really just extrapolate where you think how we can get these providers up to speed then to be able to use some of this, considering the immense amount of time they must have.
Well, it's definitely going to be a crawl, walk, run thing. And I'll mix, I realize I didn't answer your question about what kind of training, or maybe ask this question or not, the kind of training that the younger doctors in medical training, whether it be med school or residency, how much exposure are they getting to this? So I think at some of the top tier medical schools like Mayo and UCLA and Harvard and a few others, I know that they've really kind of gotten the ball going a bit on teaching their trainees about precision medicine. And I think the other thing is, with the current doctors in practice, we have to give them the tools and the evidence to feel comfortable pivoting to this kind of approach. And again, a crawl, walk, run. I'm not saying that we override any kind of consensus guidelines, no, but there is some room in the practice of medicine to decide when we should start doing that kind of thing. If you can assess that someone's at higher risk and there's some evidence to support that, and you assess that, then you're going to want to be more aggressive. You're going to want to screen sooner. You're going to want to treat sooner. You're going to want to monitor closer so you can catch them as they transition from health to disease. That's the name of the game. It's just push off the, delay, prevent, hopefully, and certainly delay onset of these chronic diseases. So I don't know, what did you say? How much of the healthcare dollar is spent on dealing with chronic disease? Lucy?
Close to $4 trillion, 90% of the $4 trillion that we spend every year.
And that's what's so interesting.
That's 20%
and also
of the GDP. The GDP is only 20 trillion.
And we're spending 50% more than the other industrialized country on healthcare, and with less, with poorer outcomes than those countries that have actually universal healthcare.
And that's what's so frustrating about this, because like as a patient, it almost sounds like it's solely not solely based off of financial incentives, but that is a pretty big factor for financial incentives for the stakeholders to then say, this is how much it costs, and then they're also going to be getting not necessarily. Oh, am I thinking about this correctly?
Yeah, absolutely, you're thinking about it right, because $4 trillion, that's a lot of zeros. I don't even know how many zeros. Let's see, it's like 15 zeros or something. When you have that kind of money out there, there's, who do you never hear complain? You never hear the insurance companies complain about any. They never complain. You never see them going, oh, we're getting screwed in this whole deal. But you may hear doctors, and who else doesn't complain too much? Big pharma. I mean, the people who are doing great are really doing great. And, let's be fair. If your job is to sell X diabetes drug and you're putting your kids through college on that, then the last thing you want is for diabetes to go away. Am I right? I understand how we got to this place, and I don't know that there was much malevolence in the whole thing. I mean, certainly the stakeholders are dug in, blah, 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 but that's the way our free enterprise capitalism, whatever. But somehow, and it's going to happen slowly and then all at once, there needs to be this pivot toward making sure this stuff doesn't happen, and they'll just have to make money in different ways, pay for.
But there's so many layers, right? There's so many layers, because we can also say that about our food industry, right? We can also say that how the food industry is managed in this country and what types of foods are pushed forward, which cause the disease,
and alcohol,
which allows our healthcare system to go in this, vicious cycle. And I think, yes, the incentives, there should be incentives. I don't have an issue with incentives, but they should be aligned with the right outcomes. And the right outcome isn't, oh, you almost died and I brought you back to life. That shouldn't be the outcome we're looking for, because that's how we're really good at that. We're really good at acute care. We're really good at bringing somebody back to life when they've been, they coded for a certain amount of time. But we're not good at preventing people from getting to that point. We're not good at preventing little kids getting type 1 diabetes en masse where it's an epidemic. We're just not good. So that's what we need to. And look, Biography Health, we can't solve that overnight. That is not something we can undertake. But I think one provider at a time, one patient at a time, we can do this. But it's important to note that this must be done with our physicians, right? With our healthcare providers, whether it's functional medicine doctors, whether it's precision medicine doctors, naturopathic doctors, any doctor with the objective of preventing disease or delaying onset of disease can join this. And I do think eventually that the system will start shifting. I think in the next 10 years that happens. I do think that now with a lot of initiatives in hospitals where you've mentioned this before, where they're sequencing babies from the get-go, identifying certain mutations and, predisposition for disease, that's happening, but not to the degree that it needs to happen, and not enough people know or understand. And again, our platform is for providers to get in on that now, ground floor, trailblazing, but also allowing patients to access this information in the format and the way that it's delivered in a very secure, health locker. That's our longitudinal cloud, right? Health cloud. Hey, I'm getting access to a longitudinal health cloud where all my information is being stored for life. And I can share that with my family members. And as a mother, as somebody who just kind of manages everybody's health in the house. I want to have this for my kids, my husband, my mom, just I can do all of that from Biography Health and ensure that everything is in one place. And here's the kicker. People don't realize when they go to all the other companies where, yes, like I said, I think they have nice interfaces, they have some nice reports, they don't have the full information that we deliver, but they deliver some parts of the information. What we have, in addition to all of what I just mentioned, but we're able to pull in medical records. None of the companies out there can say that. And that's because of the way we're set up and our platform. We can actually bring in the history, because guess what? And I don't know if this is true for you, but when you get patients, do they bring you all their information? Do they remember? I know I don't remember where I went, what other doctors I saw, what hospitals. I don't remember everything unless somebody pulls that in. I don't know.
Yeah, no, it's
I have like
eight
EMRs. My information lives in 8 EMRs somewhere in somewhere.
And
I don't know.
And no, patients sometimes are good historians, sometimes not so good. But to get to kind of detailed information, we need, even without that ability to pull stuff in through APIs that, we've developed at Biography Health. But, the old-fashioned way of getting consent from the patient, faxing it all over the place at doctor's offices, very inefficient and time-consuming. And that's why whatever companies you were referencing there don't do it. Of course, with us, since we're an AI-driven platform, we aggregate all this information, this past medical history, the current labs, family history. And I don't mean just mom, dad, but brothers, sisters, aunts, uncles, grandparents, second-degree relatives, and very comprehensive everything. Because now you have this incredible substrate to turn an AI tool loose on, and can give a lot of powerful insights. And even, and I'm not saying the doctor should, they could, but I would not depend on AI's recommendations. But certainly it does generate something of a checklist and of recommendations that you can either carry out or add to yourself, or cross them off the list if you don't feel like the current American College of Physicians guidelines would endorse something like that. Then you don't need to carry those out if you don't want to. So we have this one advantage in our country with our healthcare system, is that doctors are allowed to practice medicine. So maybe not in the health plan kind of thing, but if you're in independent practice, you're certainly empowered to do what you feel is in the best interest of your patient. And so I think for these concierge doctors and self-insured employers and people that are trying to go toward a value-based, if it's going to hurt when your employee has a heart attack, and of course it's going to hurt bad. It's going to cost the company $1 million potentially, between the cost of the hospitalization, lost productivity, all this training down the drain, et cetera. They don't want that at all. Even one of those events is costly to them. So that's who's going to be very interested in this kind of approach that we're doing.
And so with this kind of approach, and we sort of alluded to, we definitely dove right into just like the features and the benefits of working with Biography Health and what that solution is. But I would love if we can just unpack what that means for the providers then, and how Biography Health is able to sort of streamline a lot of the information that's aggregated and collected up front, to then leading up to the potential recommendations and providing all of these new insights.
So I told you the most common question I get from doctor friends is, someone just brought me this genetic information. Can I send it over to you? What do I do with this? That's one. The second most common, they go, okay, I'm going to bite the bullet. I'm going to get pharmacogenomics for my patients, or I'm going to get some kind of genetic analysis. So the first thing they do is they call me and ask me what they should do. And of course, and I don't say this for a self-serving reason, but the smartest thing they can do is just refer their patients to me. I'll order what they need, generate the reports, and give them the report and go over the recommendations and make sure they agree. That's the best way to go about it. What Biography Health has solved this problem, though, on a large scale. I mean, I can only do about 15 or 20 of those patients a month. The way that I used to do it all by hand and cut and paste and looking everything up and pre-AI and all that kind of stuff. But now we have the ability to, our online platform is, you know, where they say it's got to be simple. And are you smarter than a fifth grader or whatever? Or you, yeah, a fifth grader can navigate this platform. And it's very simple, very equipped with the easy buttons, so to speak. All they have to do is literally put the patient's name and email in there, and we'll take over. I say we, the staff at Biography Health that does this kind of thing, can take it from there. They get the questionnaires to the patients. They get the consent so we can start aggregating this information. They get the kits set out, and it's companies that we've worked with that we feel are the most trustworthy, highest valued partners we can have in doing some of this stuff, either the whole genome sequencing, polygenic risk scores, integrated risk scores, monogenic risk, pharmacogenomics, the rest. I'll say I personally, over the last 6 years, have used them all. If I haven't used them, I've talked to somebody about them, and I've been able to settle in on what is the Goldilocks solution. So what's the best solution at the best value? So we've already kind of done all that. And the primary care provider is going to get all this information back in a way that they can understand that it's much the same as a consultation. So like if I did an internal medicine consultation on a surgery patient in the hospital, I'd say, here's your guy, 75-year-old gentleman, fell down the stairs, broke his hip. You're doing a hip replacement. You want me to evaluate him from a medical standpoint. So I accumulate whatever information is out there, past medical history, etc. And I make a series of recommendations, but they're always justified by something. I say, because the person has osteoporosis contributing to their hip fracture, you're going to want to make sure vitamin D levels are there. Consider supplementing with calcium and magnesium. And, you know, they may need more significant treatment of their osteoporosis in the future. But I say, and that style is the Biography Health style. We don't just say, give 5,000 IU of vitamin D a day. We say, because of this, because of the risk of this, because of evidence of that, it's recommended. Look, so it's that style, that doctor to doctor. This is what I recommend. This is what I see. This is what I recommend, and this is why I recommend it. That's what doctors want. That's what they need.
And now tying into something that Lucy mentioned was this health locker. Then, I mean, theoretically, then you have these recommendations, but then in traditional healthcare systems, then and how we've been treating it, the monitoring of those ongoing recommendations and that real-time patient engagement and feedback sometimes sort of gets lost. Then, can y'all?
Yeah, well, I'm probably going to answer the question I want to answer or not answer the question you're asking. So if I don't answer the question, come back to me.
You can answer whatever question you want. You're the face of the show.
So you sequence once. So once you've done whole genome sequencing out of someone, once they have done the pharmacogenomic microarray, once they have, and those are the main ones, that variant call file is not going to change. There's no need to resequence you in 6 months or 12 months. But guess what? The body of knowledge behind precision medicine, and this is going to be driven a lot by AI. And I talk as if this is unique to personalized precision medicine, but I'm sure it will affect every industry out there, and every worker and executive and manager out there is going to need to consider that the rate at which new information is coming that has to be integrated into whatever it is you're planning to do. I mean, if you're designing a submersible to go down on the Titanic, you're going to want to know that one imploded, a year ago, and maybe incorporate some of what was learned in that. So in other words, that you're going to want to not have to recollect saliva samples, but you're going to want to grind, get additional new information. There could be changes in family history, changes in medications, changes in lab values, changes in current health status, how the patient sleeps, wearable technology. Oh, I just got this Apple Watch. Oh, now I have more detailed information about my heart rate variability, whatever. This type of new information that can get added to the data set that has the genetic information laid against it, and an AI tool turned loose on it, it's going to come up with new recommendations, right, that weren't there 6 months ago. Yeah. So what's going to be done on an ongoing basis is something not nearly as costly, because they're not the original testing, but just the cost of maintaining the platform and running through all this stuff. So it's meant to be on an ongoing basis. And that's why I think Lucy had alluded to it earlier, and I kind of thought that's what you were getting at with the health locker, that you're going to need a super safe place to keep all your information, to add to it and run it back through the hamster wheel, so to speak. And those hamster wheels are getting better and better every day, right? So you're going to want that new information, and this is going to be an ongoing thing that keeps up with the changes.
And I'll add to that, because I think there are two key points here. If we look at it from the provider's perspective, the provider wants to know, it's not enough to ask, well, are you eating healthy? Are you exercising? When I go to my doctor's office once a year, my doctor really doesn't know what my lifestyle is, right? They can ask the questions once a year. That doesn't really tell them about the frequency and how I'm living my life. And in essence, they can't really help me when they don't have all that information. So Biography Health gets that information to the provider because they have access as the data aggregator puts this together, right? It's that continuous engagement. So the provider is getting a more holistic picture of their patient. The provider is getting this digital twin of their patient over time and can give better recommendations. And another key point that you brought up, and that's really, really important, because we're in the age of DIY. DIY everything. Do it yourself. Go get your supplements. Go get your tests. You can go to Quest and buy any test you want. Your doctor does not have to order it, right? Well, that gets into dangerous territory, because we've all used Dr. Google. I'm guilty of it. I Dr. Google everything. I think we all have, some sort of a chondriac syndrome, whatever, chondriac, right?
Yeah.
And that's not a healthy place to be. Aside from anxiety provoking, where we're all trying to be a doctor and trying to get answers because there isn't enough information. The difference is, number one, when this information is being fed through the Biography Health portal, I'm getting real doctor recommendations. Yes, the AI is giving recommendations, which is great. I'd love to interact with AI, and I think that's an important part of engagement. But I'm also getting real human doctor recommendations. That's very important piece, because these doctors have gone to school. They can see patterns. They can connect dots in a way that the AI can't, because the AI does not reason, right? The AI does not have the reasoning functionality the doctor does. So I still want that human involvement in my care and not just the technology. Did I freeze on you guys?
No, you're great. So I think that
did I freeze my internet? Okay.
just a bit, but it's fine.
I think that patients do want to continue having their primary doctor drive the ship, so to speak. But this AI is getting better. And then plus the way we use AI is going to get better. So instead of AI looking at all the everything, including the garbage strewn about the internet, I mean, sure, there's like well-vetted American College of Physician guidelines or Choosing Wisely or, all these different guidelines out there. And then there's up-to-date and other medical society guidelines, et cetera. I mean, all of this would be a much better data set to be a trusted data set to be using the AI tool with. So AI is going to get better, and the types of it's just going to accelerate. And I'm not saying that it's going to take the place of doctors at all. I'm not, but if you want going to be a really good doctor a year or two from now, you're going to want to be really smooth at using this technology. And the other thing that you alluded to was incorporation of new omic disciplines. So, for example, some of the listeners maybe have heard of methylation, where it's kind of the on-off switches for the genes. We're going to be able to look at those patterns and predict risk of disease. I just saw something released today in the journal Genetic Engineering that there's a group that has identified methylation sites that can predict early onset Alzheimer's. And not just that, but where that increased risk is coming from, not just the ApoE4 thing or whatever, but is your risk increased because of something you're doing with your exercise protocols or lack thereof, or something with your diet, or something with your sleep? They have these aggregated risk scores based on changes that occur to your DNA that are part of what happens in your general experience of life, so to speak. And that information is going to be very useful to help mitigate those risks that you can identify. I'm at increased risk of diabetes. Well, how am I doing with that? Well, you can look at the methylation patterns, and you might be doing a lot better if you ate at different times of the day, or you might, if you're eating different things, maybe more carbohydrates. I don't know. Just throwing that out there. I mean, there's going to be information available in those methylation patterns, and of course, proteomics, the different proteins that are present in your blood. So the science is going to get better and better. The data, the medical science is getting better and better. The data science better and better. The AI better and better. And then these tools, there's just going to be more of them. And this so-called multi-omic approach, where you're looking at the methylome, where it's the DNA is methylated, the proteome, what kinds of proteins are in your blood from day to day, can go right alongside the genomics, and it every one of those layers, it's 1 + 1 = 3. So that each one helps inform the other, so the sum of their parts it's greater.
Yeah, and I would add that in terms of engagement, that is how we increase engagement between provider and patient. And for that healthcare consumer who's getting real-time updates, real-time information, they're going to be more engaged, right? Because we know today, even if providers are giving preventive medicine advice or preventive health advice to their patients, only 25% of the time those patients follow up on that advice. So there is data now showing, because of genome-based, so gene sequencing and polygenic risk, that engagement goes up by about 30%, which is very significant. Yeah. Because what happens in that case is I'm now aware of my risk, and now I have priorities to chase, right? It's not kind of a random, oh, I need to eat healthy, I need to exercise.
It's not this population level advice that one size fits all. One of the first questions I'm often asked by people that are not in precision medicine or not one of my patients is yeah, but how often do they follow your advice about what to do based on their genetic risk? And I'm like, almost all the time. I mean,
Yes.
way more frequently than those, admonitions. Oh, you should quit smoking. It's one thing to tell someone to quit smoking. It's another thing to say, well, you know how your mom got lung cancer. You have the same genetics that would predispose you to lung cancer if you were to be a smoker. So put that in your pipe and smoke it.
Well,
Yeah,
and I've been going, I go to the doctor, right? And I love my doctors, don't get me wrong. And there's a good conversation, but they know my history. They know I have diabetes risk in my family. And they know that's a concern. Not one doctor before you has ever said, listen, let's get you a CGM. Start wearing a CGM. Let's watch how you respond to certain foods and drinks. And I'm doing that now. And I can tell you, I've been surprised multiple times. One example is organic coconut water. It's good for you, right? It's really good for you. But my sugar spikes because there's a lot of sugar and people don't think about it. Yeah. I drink it because it's a good drink, but I spike like it's a soda. So I'm going to have to be very vigilant of drinking organic coconut water. It doesn't even have added sugar, right? And
so what you're going to have to do is just pour about an ounce of that coconut water into 32 ounces of seltzer water, and then
there you go. Right. And I love learning that. So I think that's really important. Is they may even have, of course, they don't take the full history that we do, but they have some of the history, but there's never really true action that starts ahead of time.
Yeah. So I'm a big fan of doctors myself. A lot of times doctors don't like other doctors. I tend to like other doctors. I'm going to say,
I like them too.
Yeah, I'm going to say that they're really not given the opportunity to succeed right now. This day that, and it's not just Biography Health and us, but I mean, there's a lot of people out there, trying to bring this awareness of the control you have over your destiny. Most people, I think that aging and sickness is you're like a leaf on the wind. It's either happens or it doesn't, or it's an act of God, but most people are not aware. Obesity is a risk factor for cancer. Diabetes is a risk factor for cancer. High stress life, it can be a risk factor for certain cancers, certain things you eat. You just have to know where your risks are, get informed, and mitigate those risks. And the healthcare establishment will come around to it. In the meantime, you have Biography Health and some other excellent companies out there that will help you be proactive and preventive, and you just got to avail yourself to it. The thing that I'll say for Biography Health, that the real difference maker is we're going to have your primary care provider involved in the process, get their buy-in, and that's going to make all the difference in how the execution goes after you get this new information.
Yeah, and I was going to say, so now transitioning into bringing this level of personalized care to others, would love to hear about the vision for Biography Health, the strategy and plan to now start rolling this out to other providers.
Well, I would say we've already started executing on that, right? Because we...
that's very true.
Right. So for the listener here today, we're evangelizing this type of healthcare delivery because we believe that it's the future. And I'm going to quote Dr. Stanford that the future is here and it's not equally distributed. Did I say that right, Dr. Stanford?
The future is here. It's just not evenly distributed. Not my quote. I heard that one about 3
It's not Bill Gates. It's not Bill Gates.
That's
it's
right.
Dr. Stanford.
Yeah, okay. It's either Obama or Bill Gates for everything.
Some smart person, right? Yes. So for us, we I think it's one thing to say, yes, we can go to individuals and ask them to sign up, but that takes away from the ability for them to stay in their medical home and continue to work with their providers and have a longitudinal health plan, right?
Yeah.
So we're thinking long term, because prevention is a longitudinal plan. It's not something that happens overnight. This isn't acute care. It's not ER. We don't save a life overnight, but this is something that we work with our physician, with our caretakers, with our nutritionists, and over a long period of time, we can see some real impact on our health. So for us, it's important that we have the buy-in of the people or the physicians that touch so many patient lives. And that's a lot of the primary care doctors, but also specialty care physicians, because we do have a shortage of primary care physicians, and a lot of patients use specialty care as their primary care. There are many patients who go to their cardiologist for primary care, or their gynecologist, whichever specialist. So our goal is to bring this to, of course, our I would say, trailblazers, who are concierge, functional medicine, naturopathic doctors. So we are approaching them, and then we do have other physicians who are not necessarily in those categories that are very interested in this type of care, and we're working with them right now. And it's that expert, right? So the patients that come through Biography Health get expert level care and expert level advice through our AI engine, in addition to all of the other things that we've listed. And we really think that with the physician buy-in, with a provider care team buy-in, patients not only get to benefit from the platform, their physician, but if they already have health insurance, these physicians are the ones ordering tests, really good tests, blood work, diagnostics. It's really important that imaging, we have to ensure that they can benefit from that as well, because they can go and get those tests. If they're high risk, insurance will pay for it, right? If the doctor can find
oh, absolutely. Yeah, absolutely. And especially if the rationale is laid out well in whatever supporting paperwork, which is why when we make a recommendation, we lay out the rationale for it. Just anecdotally, when I make recommendations and I've ordered them myself and I submit a copy of the report with the rationale, I'm just going to say 100% of the time stuff gets covered. I mean, certain things insurance companies just don't pay for, but I mean, things like I would move the colonoscopy up from 5 years to 3 years. They seem willing to do stuff like that. And when I've had primary care providers that I give that report to, they carry it out and it's always covered. So, I mean, we'll give the insurance companies credit for that. If you can show the rationale for why you're ordering what it is you're ordering, my experience is they'll more almost always cover it, especially if they know you. You know, if there's a new doc, you know, it might be harder for new doctors or someone is not an MD or DO or whatever, someone that is a naturopath or chiropractor. I'm sure they have all kinds of trouble getting stuff approved. I don't know. But if the insurance company knows you and knows you're going to provide this kind of rationale, they'll eventually stop asking for the backup. They'll just approve it.
Yeah, and a lot of patients ask, well, what about HSA, a health savings account, or an FSA? Is that covered? Our tests are covered by HSA, FSA. So if they want to pay through with an HSA, or if they want to submit our invoice to the HSA, they will get covered because these types of tests are covered. So I just want to make sure that
I was referring to like extra stuff. Like we would say, okay, because you have had 3 polyps, the last 2 colonoscopies, and we've looked at your polygenic risk scores. Yeah,
That's a great point.
yeah. No, I mean, well, so the other thing I'm going to say about the HSA and just paying cash in general. So, newsflash out there, a lot of times for radiology type studies, so CT scans, MRI, if you are paying cash out of your HSA, the amount that you pay is often not much different than the 20% copay. Because when radiology centers are billing insurance companies, they mark it up to whatever the insurance company will pay, and you're still paying 20 or 30%. But the actual cash price they'll take is often about 20 or 30% of what they're charging the insurance company. So a lot of times, and there's some good apps out there. I think most of us have heard of GoodRx by now as far as medications go. So there's something called MD Save, where you can go on there online and find out the cheapest place in Los Angeles or Denver or New York City.
This is a free advertising for them because we're not sponsored. Maybe they should sponsor us.
No.
But we're not
on the same boat. We're all trying to get the best healthcare out to people.
That's right.
And work within the system that we've been dealt some bad cards, folks. Let's just, I mean, the current healthcare system, I think someone started to compare it to outcomes in other industrialized countries. By the way, it's not great in other industrialized countries either. I mean, if you think that nationalized healthcare necessarily solves the whole problem, it doesn't. I mean, that's a step in the right direction, maybe. But what really needs to happen is a change in mindset from being reactive to proactive. That's what needs to change. But yeah, no, there's lots of ways that, and I worry for those insurance companies 10 years from now. Who's going to need them? The only thing you're really going to need them for is that catastrophic stuff or expensive drugs that haven't hit their 13 or 15 years or whatever before you can start selling generics. But just to pay cash for better care.
Well, and we're seeing that there's an affluent group of people today that refuse to purchase health insurance.
Yeah.
They can afford health insurance out of pocket, but they refuse to, right? And they turn to concierge medicine. They turn to, they would rather pay for a ticket and fly to another country and get procedures done than pay for health insurance. Because again, I think that there's a perception of diminished value. So that's important. And also to note that from a spending perspective, the average American with chronic care conditions spends out of pocket, in addition to their health insurance, they spend about $7,000 a year out of pocket on whether it's procedures or medications, so on and so forth. So if that's the case, then I want to prevent having to spend that money every single year. Number one, and that increases. And number two, I don't want to even have the condition because it doesn't feel good to be sick, right? So it's just so simple that even if we're going to spend a few $100 here and there for prevention, the payoff is just multifold. The payoff is it's priceless, really.
Yeah.
So with the payoff being priceless, and then also trying to get the best healthcare out there, if somebody is listening, whether they are a patient that wants to get their provider involved, or let's say there's a provider that's listening to this episode, what is the best way that they can reach y'all? And then also, if you have any final words if they are listening, to speak to them.
I would say you go on our website and you just get started. Just click on that button, put your name, email. That's really it. There isn't a lot of information and we will reach out to you. We will talk to you. We will answer any questions that you have, whether you're a provider or a future patient. And for future patients, don't wait. It's already too late. I'm personally working on reversing things at this point, and I think I'm pretty healthy. but I have a lot of work to do. So especially if you're younger, don't wait. It's never too early.
Yeah, problems are always easier to solve when you catch them earlier on when they're smaller. But it's hard for the average 30-year-old to,
Like myself, except I'm not 30 yet. I have one more year left, so almost there. But
yeah, it's only when people get into their 50s and stuff that they start feeling their mortality and wanting to make sure that they're getting the most out of the aging process, so to speak, the most anti-aging out of the aging process.
Awesome. Well, I thoroughly enjoyed this conversation. Lucy, thank you so much for hopping onto the podcast. Had a great time, really insightful conversation, and we can't wait to have you back for a future episode. Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.